commit
Thank you,
this
Father.
into your hands, praying that you would speak to us, grant us enough connectivity, help us to learn. Thank you, Father, for we prayed in Jesus' name. Amen.
Amen.
So once more, I welcome us to this meeting. We will be on a very fast lane because time is fast spent already. I'd like to recognize national schools on this call. You are well recognized. National schools led by Dr. Maureen Nwafo. You are well recognized. Please permit me, for lack of time, not to go into calling the names one by one. I have also cited a veteran in the world of clinical pharmacy, Professor Bola Joko. I know. So you are most welcome. Thank you for joining us even at this late hour. So at this point, I want to welcome everybody. Permit me now to call on the speaker so that we can be on the fast lane. The world of cancer and pain is a world that people like dodging from. They do not like going into it. But our speaker has carved a niche in this field, honing her skills there with academic research areas in drug discovery, AI-guided phytochemistry, nanotechnology. And then she has actually worked on converting herbal medicine extracts from yam and shop into nanomedicines. And this has been exploited in the treatment of cancer. She has won various awards ranging from African Women in Agricultural Research and Development Award. She has also won the prestigious Bill and Melinda Gates Foundation Award, and she has won Organization of Women in Science in the Developing World PhD Award. She has authored 4 health books, and I'm sure there are many others on the way. So we are very privileged to have with us Dr. Joy Funanya Odumegu from the Department of Pharmacognosy, Faculty of Pharmacy, University of Lagos, Nigeria. Dr. Odumegu, please, you have the floor. Thank you so much. Dr. Joyma, you have the floor. Maybe you are trying to speak, but you are muted. Kindly unmute.
Very much. I was knocked off for a few minutes. I got in 5 minutes to the time. So I missed the name of the person that introduced me. I don't know if he's from Ahuchogo.
Yes, I'm Pharmacist King David Ahuchogo.
Okay, thank you very much. I got the bit where you were talking about the books and you said you are sure some more are coming. Keep up that prayer. Thanks. Good evening, everyone. I'm very happy to be here. I'm Dr. Joy Odumegu from the Department of Pharmacognosy, Faculty of Pharmacy, University of Lagos. I usually introduce myself as a herbal medicine expert because that's what I've dedicated my life and my research to. So without further ado, I'll share my screen because I have a PowerPoint presentation. Okay, so we're talking about unveiling the hidden risks of herb-drug interactions and overlooked threat to patient safety. I've already introduced myself, so I'll get ahead with it. On these contents, based on these contents, I'll introduce everything very briefly, looking at the mechanisms of herb-drug interactions, some cases, clinical evidences, and implications for healthcare providers and patients. And safe practices and policy recommendations. So, when I say the rise of herbal medicines, we know that we've had herbal medicines from time in Africa, is actually part of our culture. And over time, there has been a bid to erase it by colonialism, but it was unsuccessful. Our people still use herbal medicines a lot, and it's getting more and more refined. It's getting better and better. In fact, in recent times, it's growing outside Africa a lot. You know, we know that herbal medicine is not exclusive to Africa, it's also in Asia, it's also in Europe. So, but my discussion today is going to be based solely on Africa, specifically Nigeria. So many people have realized the beauty of nature and natural things. You know, people are moving things back to healthy, natural things. And the part of the problem before is we didn't understand a lot about the mechanism of action of many of the herbal medicines. You know, they are effective, but we are not able to explain. So it was regarded as juju or magic, but it's not, it's science. So looking at briefly at the mechanism of herb-drug interactions, which is a very important phenomena in health. And you know, when one is preparing something, you get to read recent things about it. As I was preparing this talk, I realized and learned a lot more of recent things, recent findings, research findings on this particular topic. And I was fascinated. I'll tell you as I go on. So herb-drug interactions occur when compounds in the herbal remedies alter the way pharmaceutical drugs are absorbed, metabolized, or excreted. And this can lead to reduced drug efficacy, increasing toxicity, which we don't want at all. You know, already we know that drugs, conventional drugs, orthodox drugs, can be very toxic. So increased toxicity is bad news. And then some unexpected side effects, some of them inexplicable. And I would like us to look at something very interesting. For starters, herbs interact with herbs, interact with foods, and interact with conventional drugs. So pharmacists, healthcare professionals have a lot in their plate in this particular area. Because, for instance, your patient, how can you regulate the food that they're eating if you don't even know that the medicine you've prescribed or you've dispensed is interacting with their food? So herbal interactions could be with food, could be with drugs, which is what we are discussing, and it could be with the herbs itself. In fact, one of the things I found out is, you know, herbal medicine is it now. Everybody knows something about herbal medicine. And sometimes when I see these things on
You can't hear you again, man.
All right. Yeah, I think she's having network glitch. Okay, she's back. Dr. Joy, welcome, ma.
Thank you. I was knocked off. I was warned. I was told that my internet is unstable. But you know these things, we move on. So I realized when I was knocked off, so I stopped talking. Can you hear me now?
Yes, we can, ma.
Yes.
Okay. So I was talking about, yeah, thank you. So I was talking about the vast possibilities that we have. Oh, your internet is unstable. Anyway, when I'm not off, I can tell. So the different interactions that one can have with herbs. And I was talking about polyherbals, that people tend to want so many things in one preparation. Is dangerous. And this I can confirm with my recent findings about herb interaction that people don't even know about. And for me, it was more like it's a bit too much of a good thing can be a problem. Okay, so and I'll give you an example. Historically, there are records of herb interactions with minerals. I'm talking about soil, when one uses soil for medicine or food.
Ma, we're not hearing you, Ma.
And more particularly, formally, in the 20th century, the interactions between St. John's wort and the antidepressant, that was about maybe not the first, but the one that resounded a lot. People were very concerned. In this case, St. John's wort was reduced efficacy of antidepressants. That was that. It was a whole detective story. I don't know.
All right. We have lost her again due to communication. While we wait for her, um, I think I've cited. Okay, she's back. Dr. Dumegu, are you back? All right. So
I'm back again. I'm sharing my slides. Can you see the slide?
Yes, we can, ma.
Okay. I'm putting off my video because sometimes it may be the problem. Okay, I was talking about historical evidence of herb-drug interaction. And particularly in Africa, traditional healers have tell people not to combine certain herbs. For instance, bitter leaf or garlic with certain Western medicines. And they tell the people, I'm talking about the traditional healers that are genuine, that know what they are about. So because they can cause unexpected effects. We're going to look at what exactly happens. Why are these things dangerous for the patient? So herb food interactions. I'll discuss herb food very briefly. So we know of grapefruits and certain medications, statins for diabetes, and some calcium channel blockers, that grapefruit interact. It inhibits the cytochrome P enzymes, increasing blood levels of these drugs. And this leads to toxicity or enhanced drug effects. You know this already. Maybe you don't know about grapefruit. Maybe some of you know. Then herb interaction. This is where it gets very interesting. African basil, ephiri, or ntraum, and clove. Many people use the two as teas. Both contain eugenol, and other phenolics. And they are powerful. Ephedrine is a powerful antimicrobial and anti-inflammatory herb. So the same with clove. So they can work synergistically, their antimicrobial effects, and cause possible gastric irritation. Why is this a very strong possibility? Because they are both food and people feel safe. In fact, I've told people that if the herb is food, it's basically fine because it's food. But then you remember that clove is a spice and is not used in large quantities. Maybe ephedrine, yes, people use as vegetable in stews. But when you are taking it as medicine, because it doesn't have the oil and the crayfish and the other things, one has to be more careful. And this is what we have to be telling people. Then bitter leaf, okay, that's a mistake there, is bitter leaf and neem. Both contain compounds that lower blood glucose by enhancing insulin sensitivity. So they can cause severe hypoglycemia or dizziness because they are both very powerful hypoglycemic drugs, herbs. So when they are used together, what happens is that people keep looking for, herbal medicines don't work as fast as conventional medicines. It takes time because it's natural, but people want the one that works fast. But that's where there is a problem. That's where patients get it wrong. That desire for speed to get it and get it resolved immediately. So people tend to want that speed by combining so many and forming what I call the polyherbals. So herbal interactions with drugs. And when I say drugs, I'm talking about orthodox medicine. So we have Venonia, bitter leaf, can interact with metformin, which is an anti-diabetic drug, then through enhanced hypoglycemic effect. So it increases the insulin sensitivity and glucose uptake, potentiating metformin. It actually makes it work better or faster in a way that is not too helpful for the patient. Then we talk about neem, which is an anti-malarial. When we take it with chloroquine, which some people do, I don't know why, because neem is a powerful anti-malarial. Once you start taking neem, I know because that's what I'm using now. I don't use orthodox medicine at all for malaria. One notices, I'm still here. So it reduces, if it's mixed with chloroquine, it reduces anti-malarial efficacy because of the work on the enzymes, the CYP enzymes, increasing the metabolism of the antimalarials and lowering plasma levels. Then Garcinia cola, bitter cola, with aspirin. Sometimes people just take it as snack. Maybe somebody is treating, has a headache and got some aspirin, and the person is also taking bitter cola as a snack or to ward off sleep. It has a small amount of caffeine, not as much as the other cola, but it has some caffeine or an NSAID. It increases bleeding risk, So bitter cola has antiplatelet activity, which in some instances it could be useful. And then it works in synergy with NSAIDs to impair blood clotting. Then ginger. I just brought the very common herbal medicines, especially the ones that are used as food as well, because those are the ones that are abused. I talk a lot about misuse and abuse of herbal medicines. I think the one of ginger is well known. Its interaction with warfarin, which potentiates the anticoagulant effect. And ginger inhibits thromboxane synthase, the enzyme, and has antiplatelet properties, a little also like Garcinia cola. Then garlic is a powerful antihypertensive. Many people swear by garlic. So if one takes it with a drug, for hypertension, it makes an additive hypotensive effect, which is synergistic, and it promotes vasodilation and inhibits the ACE enhancing the effect of the drug, which is not good for the patient. You know better than I do about these things. So I wanted to explain for those that are not pharmacists what it means when they say enzymes are the cytochrome P450 enzymes, which are a family of liver enzymes that help to break down or metabolize drugs in the body. So when the chemical compound in neem, there are so many. There are so many. There are saponins, there are flavonoids, there are phenolic compounds, like catalyzing their effect. Malaria, chloroquine, artemisinin get broken down faster than normal. You know, some of them works better when there is sustained release, so that there is not a dump of all the chemicals in the system. So what are the consequences of this? Faster metabolism. The drug is cleared from the body more quickly before it can deactivate the parasites causing the malaria. Lower plasma levels, small amount of the drug remains in your bloodstream because it is cleared rapidly. Then all this culminates into reduced efficacy. The drug may not work as well to fight malaria. So why does this matter? You know, I just wanted to talk about neem, dogoyaro. If someone takes neem while on anti-malaria medication, the neem could make the medication less effective. And this could lead to treatment failure or drug resistance. And I want to talk a bit about drug resistance because we're having before, when you hear about drug resistance, we are talking about mostly only antimicrobials, you know, the superbugs. But now in cancer, which is heading back to nature. So we don't want drug resistances because some of these drugs took years to be developed, and we want them to continue working for us. So I've had experience of people not knowing exactly what I'm talking about, but I put the pictures for a reason. Bitter leaf plant. So this is what we know as bitter leaf plants, Vernonia amygdalina. But then we know that there are so many other plants with leaves that are bitter. So misidentification is also a problem, you know, interaction issue, because people take some plants thinking is the other. Some people, bitter leaf, and what is called in Nigeria may be different from what is called in Ghana. So I brought this out because of misidentification issues. Then neem leaves. These are neem leaves. I know that most people know, some people may not know it. Then bitter kola seeds. So I just had an addendum there because I've heard of people, when people say that when it's dry, they throw it away. When it's dry, so far as it's not spoiled, don't throw it away. Just put it in clean water overnight and allow it to soften. Don't waste it because this is a powerful drug, okay? But please don't take it with conventional medicine. We tell the patients. Then ginger rhizomes. I don't know if you know, there is a crisis of ginger. There is a bug, an infection that has attacked ginger in the where is mostly produced in the north. So there is a lot of what they call fake ginger. I don't know how you can fake a plant, but I see what the people are calling fake because it doesn't look like the normal ginger that we know. So my suggestion is grow yours in your home garden. It could be in a pot or in a bag. These are garlics. There are some garlics that they say coming from China. They are whitish. People call them fake garlic. I suppose they are GMO. They're genetically modified plants. So what does herb-drug interaction? What is the implication for healthcare providers yourselves and the patients? So it has significant implications for pharmacists in Nigeria, particularly where we use traditional medicine widely alongside conventional therapies. Many people cannot afford. The first issue is people can't afford some of the drugs, so they go for herbal medicine. But then there are some conditions that they may not the herbal medicines for them, so they go to the hospital and they get some drug and they continue with the herbs that they were taking. Okay, so patient's therapy outcomes. The pharmacist should assess whether herbal use is compromising drug efficacy or safety. But before the pharmacist can do this, the pharmacist need to know. I think mostly they ask, are you on any herbal medicine? And sometimes the people would, that what they are taking, if they've soaked ginger in alcohol, ginger is food. So maybe when you ask, are you on any herbal medicine? They will say no, because for them, it's not really medicine, but it's a potent medicine. Ginger in alcohol is extracting everything inside that ginger. So it's so crucial, considering that we keep on keeping on. Okay, so where was I? Okay, then when I was preparing this, I said the pharmacists have a lot of work to do, because sometimes the interaction could be from the food. I had mentioned it previously. It could be from the food that the patient is taking, and the pharmacist or the healthcare provider is unaware. So another implication for healthcare providers is medication reconciliation and counseling. So to ask patients about herbal use, many patients don't disclose. I've said this before, because they don't think that they are on any medication, that they are taking herbal, because what they are taking is what they usually use to prepare food, maybe a spice, But some of them say, if they are specifically asked. So to educate patients, to explain potential risks and guide the safe use of herbs with the medication. For instance, this thing of garlic and bitter leaf, to be very careful, or the clove and ginger. So pharmacokinetic and pharmacodynamic, and explain clearly to the patients, because patients these days are mostly half-baked doctors. That's what I call them. They've attended, almost everybody have attended medical school on TikTok and Facebook. So they feel they know. Sometimes they even argue with you when you are telling them. The thing of herb-drug interactions is so serious that they need to know what will happen to them if they continue, with that unsafe practice of mixing the two. In my department, we have a herbal clinic, processing model herbal clinic, and people come in, we clerk them for some minor thing, not so minor. We have anti-diabetic teas, and we have some teas that we recommend to the people, because they are the offshoots of research from lecturers in my department. And for diabetes, that she was just diagnosed, and they've put her on a diet, and she knows that she cannot keep to that diet. So she wants to retain her normal diet and use herbal medicines to treat the diabetes. So I had to counsel her that it doesn't work that way. She will still need to abide by what the doctor had advise her about diet. And then, when she is done with her medicines, and she's, the doctor, that whatever she's doing, she must have to do it with the agreement with her healthcare provider. She didn't like it. She wanted to be told, no, yes, very good, you're in the right place, keep the drugs here, take this tea, and you are good to go. But it doesn't, you and I know that it doesn't work like that. Then continuing education and research to stay updated, like you are doing already. You have new interactions are constantly being discovered. This thing of to keep learning as you're already doing, and to contribute to evidence. In Nigeria, pharmacists can help document local herb drug interactions to build a stronger evidence base, and also to listen to the patients. People know a lot, especially when it has to do with their body. Because in recent times, or maybe some people knew before, I'm just getting to know in the last 1 or 2 years, that Zobo drink leads to miscarriages. I didn't know that pregnant women, I started seeing it on Twitter. People are talking about it, and it's as if it's been going around, but people were not too sure until in recent times they've been able to pinpoint that it's the Zobo drink that was causing that. So, of course, to already start telling pregnant women, keep off Zobo until you give birth. For otherwise, Zobo is a very high content of vitamin C, is a powerful antioxidant. So collaboration with natural products researchers and healthcare teams will also be a safe practice and a policy recommendation to bridge the gap. Pharmacists can foster this respectful dialogue between traditional and modern medicine. In many countries, I wanted to say developed, but I've not seen it, I've heard, but where I've seen it is in India. You enter a hospital, you see to your right or left, herbal medicine, to the other side, conventional medicine. You do whichever one you want, because it's there like that, because the diagnostic equipment, because you first of all need to know what is wrong with the patient to be able to start treating. The diagnostic equipment is in the hospital. So by the time they've diagnosed and the doctor has told you what it is, you now make a choice which one you want to use. So this mingling of two very important aspects of healthcare is very important. We're getting there, to try to integrate the traditional medicine with the modern one. Okay, that's what I was about to talk about now, to promote integrative care, ensuring both systems work together safely, benefiting patient outcomes. So these are some selected references. Thank you very much for listening.
Okay, thank you, ma. I think our moderator is back, so please permit me to hand over to Dr. Obiajuru Wayemeru, who I was standing in for. Dr. Obiajuru, please. Yeah, please.
Okay, thank you very much, Pharmacist King David, for holding the fort while network was showing me Pepe. Thank you very much, our presenter, Dr. Joy Odimegu, for a very, very insightful presentation. We have really gained a lot from your presentation. It's really an eye-opening experience, because you see a lot of people take herbal medications, both the ones that are processed and the ones that are just natural, that they take by themselves, get and make by themselves to take without taking into cognizance the effects on other foods that they are taking, drugs that they are taking, and even some disease conditions. And you see a lot of people peddling some of these medications and saying no side effects, no interactions. You can just take it with anything, So now we've learned a lot, and we've come to realize that yes, a lot of these things we have to be careful with some of them, even as much as they are great. They may do the things that we actually expect them to do, but at the same time, we also need to be careful, with other foods and diseases and other drugs that we may be taking with them. Like you mentioned, hibiscus leaves, that the common Zobo drink can cause miscarriage. Then also recently from one of our clinical presentations, I also learned that beetroot that most people commonly use to improve their blood levels can also cause thrombocytopenia. And I
Oh,
think I
wow.
was also one of the people that's also passed through that, because for some years, because there was a time I had anemia. So for some years, I've actually been taking smoothies that always had beetroot.
Oh,
And
my.
recently, when I did my full blood count, my platelet count was low. So
Oh,
when we had that meeting some weeks back, and I learned that, as in I was like, oh, so could it be the reason why? Because this is over like 3 years I've been taking beetroot, and I take smoothies almost every morning. So it could be one of the reasons why I had the thrombocytopenia.
yes.
So we really need to be very careful with the use of herbal medicines and natural fruits in our homes, and also what we recommend to our patients and their relations. So thank you once again, dear presenter. So before we go into the question and answer session, the way it happened, there was a lot of wait, so there was no time to recognize some of our key personnel in the meeting. So I would like to use this opportunity to recognize the presence of our CPAN National Chairman, Dr. Maureen Wafo. Ma, you're welcome to the meeting. You're welcome. I use the opportunity to recognize all the fellows of WAPCP here, all the fellows of the PSN that are here, all the national ESCO members who are here. You're all welcome to this meeting. We also welcome all the members of CPAN and even non-members of CPAN who are here in this meeting. We have Dr. Suleiman Ademola all the way from, I think, is it Uganda? I can't remember, sir, where you're domiciled. So you've
Yes.
always been part of us, and thank you so much for always being part of our meetings. So we go right now into the question and answer session. Please, if you have any question, please raise up your electronic hand so that I can call on you to ask your question or make your inputs. Okay, I can see pharmacist Abubakar Dawood. Your hand is up. You can go ahead to ask your questions. Unmute yourself and ask your questions.
Thank you very much. Good evening, everyone. Please, am I audible?
Yes, you are.
Yes, I can hear you.
Yes, thank you. Thank you so much. Let me stand on the already established protocols. First of all, let me congratulate and thank the presenter for the insights. This is an eye-opener. Just for context, I am a very keen observer of foods, how foods relate with diseases, food disease and food drug interactions. I'm very passionate in that field, and I've been very focused recently, So I just want to maybe, I don't know, it's a form of suggestion or comment. I don't know how you might see it, but I feel the topic is too broad, it's very broad, that maybe we need to split it into other subtopics so that subsequent presentations, some people might pick interest. For instance, we have this food drug interaction. Herbal, as far as I'm concerned, is quite a different topic, and then food is a different topic. Let me just give an example. For me, I consider ginger as a food because hardly would a day pass without me taking something, that has ginger in it. But if you talk of other, if you talk of other things, maybe the neem tree, as a director indica, I don't think in my life I've ever used it. So I can consider that as a herb, meaning I treat this as a drug that I take it when necessary. But this one is a food that I use it almost on daily basis. So maybe we need to classify, the topic into these two categories so that when we have presentations in our subsequent presentations, maybe other people might take interest, might pick interest in one of the topics, and then we digest them. The more we categorize them, we break them down, the better we understand, and then the more we have, the more we impact, the communities we are serving, and even ourselves and our families. And then secondly, I know this is just a relation to the presentation. As you rightly mentioned, some drugs, or let me say, yes, some herbs do interact with our orthodox or conventional drugs. But what I want to ask is, at what dose does that interaction happen? You might take this, let's say, bitter cola. How many notes of bitter cola does one has to take for that interaction to manifest when he's using, or let me say, how many leaves of neem tree does one has to take, for it to really affect, his anti-malarial treatment. So that is very, very important because some of these foods is very hard, to get rid of. You cannot just ask patient that, please stop this food because you are on this medication. Some medications are for life. So and some foods are just part of us. They are part of our culture. They are part of our, cuisines. You cannot just tell me as a Hausa that please stop eating to just abruptly one day, or stop eating rice and beans. I know it will be extremely difficult for me to stop because of, for me as an ordinary man, I might just see it as, just a theoretical or potential interaction. Maybe at that point, I didn't notice anything. I didn't observe anything. You just noticed the danger and you were alerting me. And for me to get rid of that, it might be actually a very difficult something to do. So maybe what we need to do in that context is, or in that situation is, we sit with our patients and then we recommend, maybe you are using 20 leaves of neem, for so thing. And I understand neem is part of your cuisine, it's part of your culture. So can we agree that you reduce that 20 leaves maybe to 10 over an agreeable time frame? And after that, when you come back for review, maybe we reduce it further to 5. And from that 5, maybe I might, say, no, I cannot go beyond that. Maybe I cannot go lower. So maybe we just agree that our target is quantity of that food, or that herb that I'm using, so that we do as much as possible to minimize the potential, interaction or side effect with my conventional medications. So I think this is so it's good if we can establish the dose with which these interactions happen, and then possibly if we can classify food and herbs as two different entities, then we can better understand them, and then we can come up with even more and more and more and more examples, and then we treat them locally. I just like the presentation very well because you actually brought what we use day to day. For me, almost all the examples you brought, I use them except the name, I think, and one other or two. maybe Anvita Cola and others that I have probably never used in my life. But majority of what you used as example, even me here, I'm using them. Some on daily basis, some time to time. So maybe we categorize them as food and then as herbs, so that we look at them from those angles, and then we have a better understanding. Thank you very much.
Thank you. Moderator, can I answer,
Yes,
one-on-one?
please go ahead, Dr. Joy. Yes,
Okay.
please go ahead.
Okay, so thank you very much. So from Magaji, thank you so much for your comments. They are very, it's very interesting because this thing of food as medicine, it's difficult for us Africans because some of these things are food for us. Now, the example of ginger is a powerful medicine. Ginger has the compounds, the eugenol in ginger is so powerful. The way it kills microorganisms. I mean, if you've done some antibiotic work, like I've done, and see the zone of inhibition where just the crude, without treating it, without just even the aqueous, the water extract. So for me, from where I stand, they are food and they're also medicines. Now, because they are medicines, they can be very, very dangerous if we look at them only as food. And I'll give you an example. I'm working on cytotoxic food plants that have cytotoxic principles. You know, yam, our white yam. Our white yam boiled, extracted with ethanol, kills triple negative breast cancer tumor, deplete in vitro. Okay, I'm back. So it's very
Maybe you should turn off your video and it will get better. Thank you.
That was what I wanted to suggest.
to limit some of these foods. I was just talking about yam and how cytotoxic it can be. So, but essentially, we don't eat yam. Okay, thanks. Okay, so the some of these foods, the phytoconstituents in the food plants are so powerful as medicines. So it may be very difficult not to call them medicines because that's essentially what they are. Now, ginger, you were talking about.
Hello, doctor. It has been suggested that you can put off your video so we can hear you more clearly because network is not in our favor.
Okay, so it seems she's off now. It seems she's off.
Repeat it again because I'm really interested in this. I want to know what she's saying now. What we've not heard, let her repeat it. Network, I can't hear anything again.
I can't even see her
Yes,
here anymore.
she's having some network glitches, I think.
Yes, I can't see her here anymore. So maybe for now, while we wait for her, if anybody has any inputs, any suggestions, anything to say, you could make your own inputs while we wait for her to come back. Pharmacist Zainab, is it a question you have or you want to make some contributions? If it's a question, we'll need to wait for the speaker, so the presenter to be back. But if it's a contribution, I think we can take it in her absence.
I'm back.
Okay, welcome back. Welcome back.
Thank you. So anyway, to conclude very quickly what Sam Magaji was commenting about. So I've made the point about the difficulty in classifying only as food when they're actually also medicines. Then the thing of standardization, the whole point of this presentation is awareness. So if somebody is treating malaria with orthodox medicine, there's no amount of malaria, of neem that is good. The person should not take neem at all because it's not good for the person. So when any patient is taking, okay, neem maybe is easier because it's a medicine. They may say, what of bitter leaf? So knowing this now as, for those that didn't know before, to be able to advise the patients that if you're on metformin, maybe it's not the time to be taking bitter leaf as medicine. There's a difference. When people take bitter leaf as medicine, they're not taking it as the way it's prepared as soup, bitter leaf soup. The bitter leaf soup, you squeeze out the bitter principles. You wash it out. You don't use the bitter ones to cook. Okay? So the person that is on metformin can take bitter leaf soup. But not when they are taking it as medicine, they are taking the bitter principles, which is full of saponins and alkaloids. And that's what is interacting with the metformin. Okay, so the standardization for some of these examples that I gave is that they should not even at all. For others, is that, okay, you were asking specifically about bitter cola. So is for us to now go and read up. I got some of these things from, it's like a review. It's not all the work that I've done. When you find out how many grams they used and when they were getting the interactions, you'll now be able to get maybe one seed or two. By experience, bitter cola, one should not eat more than one per day. That's from experience that I have about it. I hope this was helpful. What he was also saying about the broadness of the topic, I agree totally. So maybe subsequently, there will be meetings on only herb food interactions. Talk about that herb food, then herb interaction, only that, then herb conventional drugs interactions. Thank you very much.
Thank you very much, Dr. Odumegu. We have Pharmacist Zainab. I don't know if you're ready now for your question. Your hand is up.
Good evening, everybody. And
good evening.
Thank you. This is a very, very important topic. I want to commend the organizers for this topic. And I want to speak as an authority in herbal medicine. My knowledge for over 25 years, and I want to clearly state that I've been trained in herbal medicine from China, India. So my advice generally to pharmacists from my observation is that if you are too pharmaceutical, you will not understand herbal medicine. And if you are too herbalistic, you will not understand pharmaceutical medicine. So what do? I would recommend that all pharmacists should read about herbal medicine. You have the knowledge and you have the privilege to understand herbal medicine better than any other professional because you make medicine and you have the advantage of understanding where herbal medicine comes in and where pharmaceutical medicine comes in. I like Abubakar's question because if you talk strictly, then nobody will take anything. What is important is understanding the knowledge. For the purpose of clarification, which seems to cause confusion, what are herbal medicine? Let us take note. What is phytomedicine? Let us take note. What is nutraceuticals? Let us take note. What is food supplements? Let us take note. When you understand these four categories, herbal medicine, even by WHO, you are talking about the crude form. You are combining the crude form, either the seed, the leaves, whatever part of plant, to give a particular therapeutic benefits. So that is herbal medicine. You are using the crude form. But when you come to phytomedicine, that means you have done some standardization of that herbal medicine. You may try to take the standardized extract or you dosed it as pharmacists. Then you are beginning to look at phytomedicine. But when you talk of nutraceuticals, which are also part of phytomedicine, we are now taking functional foods. A very good example, which he said, which I think I would want us to understand, and maybe for us subsequently, this is a topic that we need to digest very well. But before we can digest it, all pharmacists, I advise you read herbal medicine. Then you find in between where we can stand and where you can recommend to your patients. What did he say? Some of those nutraceuticals, they are functional foods. You have talked an example of ginger. Ginger is a food. Nobody that does not take ginger. It depends. What is important is the dosage. Even water can be bad when you take it in excess. It is the dosage that matters. What quantity of herbal medicine or whatever you are taking that will cause a serious interaction. But they may be holistically, we look at it generally. So we need to understand, for example, if you are talking about herb-drug interaction, which is a very good topic for pharmacists, for example, BP patients or diabetic patients are asked to take aspirin 75 milligrams. Why are you taking that aspirin 75 milligrams? Because aspirin will thin the blood. So in that case, if you take a quantity dose of ginger, you may not take ginger with aspirin at that moment because ginger too will thin the blood. Garlic too will thin the blood. So it's either an alternative. But if you take aspirin and take garlic, I would recommend you take garlic because apart from thinning the blood, there are some other properties that garlic exhibits. Reduces cholesterol level. So hypertensive may have excess cholesterol, diabetic may have. So what I'm saying, because I don't want to give another lecture, but I had to make clarity because I have gone through this research work, I've done the training, and I've seen the difference where herbal medicine and pharmaceutical medicine meet. So we need to understand it, and we should expose ourselves to more knowledge. Because if you talk, you say, don't take, you bring them, for example, NIMP. Let me give you an example. During the COVID-19, even from US, they were sending for bitter leaves. They were sending for bitter leaves and neem leaves. You know what they were using them for? I have people calling me from US to send them neem leaves. I became interested because they were using it to steam because neem is bitter. Any anti-malaria that you know is bitter. Quinine is bitter. And then the bitterness has some property, like you have said. All these constituents, they have antimicrobial, antifungal, antiparasitic. Like I said, I don't want to give two lectures, but too many lectures, start another lecture, but it is very important we take this topic carefully. Herbal medicine, what are you talking about herbal medicine? What is the mechanism of action of herbal medicine? And when do you prescribe herbal medicine? I treat, I'm also saying practically because I receive patients. I have the first herbal pharmacy in Nigeria, in Abuja, and I would love my pharmacists to come and see what I'm doing. Patients come with hypertension. The patient comes with that. I give them questions. I ask them, I say, don't take your drugs with herbal medicine concurrently. You can space 1 or 2 hours. Do you understand? So we need to understand, and the mechanism of herbal medicine may not be completely explained technically if you don't understand because they are multi-components. So you need to play a game of understanding. Like I said, I just felt that I want to thank you for this comment. I joined in late, but I was able to capture this thing because as a pharmacist now, NAFDAC has approved 2 of my products, which are nutraceuticals. And funny enough, the products are garlic mixed capsules and ginger mixed capsule. What approval did I get for the indication? 1, they stimulate circulation, they promote circulation. Number 2, for garlic, it reduces lipid level. And they are antioxidants and they boost the immune system. So you can see these are general symptomatic solutions, which can also apply to most diseases because we need to understand. If we don't understand, we will keep on criticizing what we don't understand. And then we keep on drawing away from what? Why am I saying that? You pharmacists, you should go into herbal medicine and stop allowing non-pharmacists to take over the job. Non-pharmacists are making much more money than you because they are producing herbal medicine. And 90% of people are buying herbal medicine. If you like, tell them not to take it. They will not listen to you. So it is better we that have the audacity to produce medicine should understand herbal medicine and see how we can apply it for better efficacy and understanding of the subject matter. Thank you very much.
Thank you very much, Pharmacist Zainab. Thank you very much for such an insightful comment and all. So we are hoping, because this topic, like you said, is very broad, and you have also told us different aspects of it. So we are hoping that if you're called upon to maybe take any of those topics, I hope you will be able to oblige us to also help us gain better knowledge on all of them so that our patients can get better healthcare from pharmacists, and pharmacists can also improve their practice where use of herbal medicines, nutraceuticals, and all the rest are concerned. Thank you once again, Ma. Then I have Pharmacist King David. Your hand has been up for a while, so you can ask your question.
Okay, thank you so much. I am grateful to the speaker. I'm also glad that Dr. Zainab spoke. At our conference last year in Uyo, she served me a herbal tea, and it was very nice. She had a herbal stand. And those of us who were there testified to that. So Dr. Zainab and Dr. Joy I had 3 questions I noted down, but I think they've handled 1 or 2. So I'll just ask one. When Dr. Joy was presenting, she made a point, and that got me thinking. And I decided to bring it up here so that we can think as pharmacists and find more better ways. She said a problem herbal medicines have, in paraphrase, is that they have reduced onset of action vis-a-vis conventional medicine. People want medicines that when they take, it can start working immediately, or at least they can start seeing an improvement. But Dr. Joy noted that most times, most often than not, that is not seen in herbal medicines because their onset of action may be delayed. So, are there ways as pharmacists we can work on herbal medicines to make it produce similar or even better, rather faster onset of action than conventional medicines? I know that there are new recent technologies like producing herbal medicines as tablets. So, which my knowledge on that is still vague. So, the speaker can still talk more on that. Then, the next thing I'd want us to also look at is dose standardization. The speaker mentioned that when she's sick, she treats her malaria with neem. That's Azagirata indica. But now, I myself, if I want to treat malaria with neem, there is no dose standardization. The dose I will take may not be the dose another person will take. More still, seeing that there are differences in constituents of herbal medicines because of environment or something. Neem in Enugu and neem in Lagos, where she is, yes, may contain the same metabolites and all, but may not be in the same quantity, thereby giving to rise in problems around those standardization. So how do we handle these two things? I would want to leave other this thing as they've already been handled. Thank you so much.
Thank you very much, Farm King David. You hit the nail on the head with your second question. The first one, I'll be very quick. Nature is very interesting, but as we have a brain given to us by the creator, we can actually develop these things to be a bit, if we want it to be faster or more concentrated. Recently, my research has moved slightly, still on cancer, more of prevention of cancer, because I got to know that is a possibility. And I was looking at what other people are doing in the developed world. So what I started doing is, some vegetables have some phytoconstituents that you need to eat a lot of the vegetables to be able to get the fullness of the good from the phytoconstituent. For instance, I'll give it a specific example of what I'm doing. Broccoli. Broccoli is a temperate plant, and it has sulforaphane. Sulforaphanes have been found to prevent cancer cells from multiplying in vitro. Okay, so they advise people with that have possibility of hormone-dependent cancers, breast cancer, cervical cancer, prostate, to take more of the cruciferous vegetables, that's broccoli, cauliflower, etc. But then how much can you eat? And then for us in the tropics, it's very expensive. It grows only in Jos. So for my product, I have to import from Jos. So what am I doing? I'm concentrating the vegetable. I'm dehydrating the vegetable so that it's in powder form. So from my experiments, I did animal studies before I started. The head of broccoli, by the time you dehydrate it and grind it, it becomes like very, very little. If you take a teaspoonful could be a whole head of broccoli. So what happens when you take that 1 spoon a day or twice a day? It means that you are subjecting your system with a concentrated amount of sulforaphane, which prevents cancers, which lowers BP, which reverses enlarged prostate. So that's an example of how we can, through research, make these things work faster. Okay, or in a concentrated form. That's one. Then the second question you asked is very interesting, because before I started using neem, I've never worked on neem as an anti-malarial. I've only seen it theoretically published. So when I started looking for dosage forms, I had to go to the journals. Now, how many people can read research manuscripts to be able to get answers to what they're looking for? And that therein is a problem that we have. In fact, I spoke to my 300 level pharmacy students about this because I was discouraged. I was able to find it because I knew where to look in a research journal. There was nowhere that is written that this is what you use. I was able to find out that with 5 grams of fresh leaves of neem in 1 liter of water, you grind and sieve with 1 liter of water, and you drink it twice a day with some alcohol, because some of the phytoconstituents do not dissolve in water. You need some amount of alcohol to dissolve those ones that are not that cannot dissolve in water. Okay, so you need an amount of alcohol of a certain percentage to be able to get that, but I couldn't get it easily. And I could get what I got because I'm a researcher and I was looking at manuscripts that people have published. So why is this not common knowledge? Everybody in Nigeria knows about dogoyaro. They know about neem. and they know that it treats, people have used it for many years against malaria. But why am I finding it difficult to go online, check on Google, and I couldn't find it? You know what I think? I think that it's a bit of a business problem, you know. People selling artemisinin, I found artemisinin that does not even grow so much in Nigeria. I found a lot about artemisinin. I'm not talking about the one that is already formulated, artemita and all that. I'm talking about the crude, the plant. So what are we doing to promote our own things? The plants that are indigenous to us. So I was telling my students, now that I've found this, I'm going to be writing about it online. I actually have a YouTube channel where I talk about these things. But I need to do more. And many people need to do more. And since I teach in a university, I use the opportunity to tell people, Nigerians, talk a lot about our own things that are standardized, because it is named standardized for malaria, yes, but it's hidden in a manuscript. It's not accessible to people that are not scientists, to make our research accessible, available to the common man on the street. Thank you.
Okay, thank you, Dr. Odimegu. I have a Dr. Ejiro Akpowo. Your hand is up, so you can make your comment or contribution or question.
Thank you very much for this opportunity, and I want to thank the presenter and all those who've contributed. It's herbal medicine. It's a very broad and interesting aspect of pharmacy practice, and I particularly want to appreciate Dr. Zainab for all she's been for immersing herself into herbal medicine. Should all pharmacists study about herbal medicine? I would say maybe, but should all pharmacists understand the principles of interaction? I would say yes. The whole idea of specialization is for us to have experts like Dr. Zainab, whom, interestingly, thank God for CPAN, has made this wonderful, brought this wonderful insight as to the extent of her work. So this is the first stage: discussing, interacting, creating awareness. There are pharmacists who will be interested in it and should be interested in it and should go for it. For others, understanding the principles is crucial, so that when a patient comes to you, you should be able to know what to say based on the understanding you've gotten. You may not necessarily be able to provide the specific level of interaction, but knowing that such interaction exists, then with associations like CPAN, where we get to know those who are experts, who are specialists in this area, the issue of referrals can then come in. I particularly sympathize with our researchers. They can only do the much they can because the fund is not there. In developed climes, the research grant for only one research for one lecturer is more than the whole faculty budget of pharmacy in Nigerian schools. So they can only actually do the little they can, and hope that it makes way into practice. However, I'm happy with fora like this This discussion should continue. This awareness should continue to be created. And pharmacists should realize that herbal medicine is an integral part of our practice, an integral part of our society. You cannot tell a Nigerian patient not to take herbal medicine. He will not listen to you, like Dr. Zainab mentioned. They'll just look at you like you're joking. So it is important that when taking history, we will always want to take the history, medication history, to capture whatever herbal medicine they are taking. We don't want to omit that. And realizing that interactions can exist, you quickly look at your references and see the level of interaction. That will determine the extent of counsel or advice you give to the patient. If it's something that you are not clear about, or something that is significant, you want to quickly make reference, get in contact with experts like pharmacist Dr. Zainab and any other such professional. And very importantly, it is important that this is integrated into our curriculum. The pharmacognosy, the way we know it, I think doesn't really do us any good in practice. I don't know how many of us have done anything with, I've seen oxalate crystal, calcium oxalate crystals, or done anything with it, or the trichomes we copied to submit practical works. So we should be more practical. Some of these researches should be based on, some of these trainings we have in our pharmacy school should be based on herbal practice as it is, and how this affects patient care. So I'm happy that this is a first step. We hope to have more of these discussions and bring in experts like Dr. Zainab, who are in active practice, to enlighten us more on areas like this, to create that awareness, so that when the others have issues, they know who to run to. Thank you.
Okay, thank you, Dr. Ejiro. I think time is fast spent. I think we'll just take one more question before wrap it up for the day. So I don't know if it's pharmacist or Dr. Irene Obina Obiora. You can take the floor now.
Good evening.
Okay?
Yes,
Good
I just unmuted. Good evening, everyone. I could see from the interactions that we are discussing with a lot of pharmacists. I'm not a pharmacist. I'm actually an engineer by profession, but I am also in banking. Okay, so mine is more of like an encouragement to the sector. You know, Dr. Joy threw a lot of she gave us a lot of insights into food, drug, herb, herb, food, drug interactions. And I like the comments that came from pharmacist Zainab. Honestly, I had the opportunity to, interact with a lot of people that are in diaspora, that are into one research or the other. And it will amaze us really that, even the people in diaspora, they are interested in what is happening here. They want to see that our forests, things that we do around us here, our environment, everything is, we are keen into sustainability. And why are they discussing this sustainability? Because they know that more of the raw materials needed for, the extractions that you people do as pharmacists, the extractions that you people do from most of these natural vegetables and plants, that they get them from Africa. And because of our soil content, we have a lot of organic content in our soil texture. And this has been what has been helping us, that we have a lot of, species of trees, plants, and all that. And then if the outside world, they are interested in what happens here, then we, the indigenous people, what are we doing, really? So I actually like the evening lecture. Honestly, it was an insightful one for me. And I want to see more of this research going on. I like what Zainab said in that regard. You don't leave it for the people that are not professionals. Somebody will say he or she has a calling. Oh, it was something that I got from my great grandfather, great grandmother. She used to pick herbs, mix this and that, and get this. Meanwhile, these are the things that we should be the people championing it. So please, I just want to encourage us, because I like the time what Dr. Joy said, that when she got to India, or when you go to India, when you're diagnosed, you have a choice to make. It's either you move to orthodox medicine or you move to herbal medicine. And for me, if God gave us the plants, they are natural, and some we're even eating them as food, and we are keeping up with them. I don't think anybody, except for people that will not want to, take herbal medicine. But for me, I also feel that it should be the best option for us. So I just feel that I want to encourage us to do more research. We have bodies. I believe that as pharmacists and every other person in medical field, we have bodies that will encourage our government to give more opportunities for some of these researches, give grants and all that, so that at least we sustain what we have. And in that way, we can also help the people in diaspora, help the outside world to achieve better ways of keeping up with our health. Thank you very much for the opportunity.
Thank you very much, Irene Obinna Obiora, for being part of us. As it's good to know that an engineer stroke banker is here and participating in what we are doing. Then, although I said that would be the last question, maybe we'll just give 1 minute to Ugweze Peter. I won't assume everybody's a pharmacist anymore. So, Ugweze Peter Chukwa Luka, just 1 minute, please, to make your comments or contribution. But before that, Pharmacist King David, your hand is still up. Is this the old one or this a new one or something? If it's the old one, please take it down. So, Ugweze Peter, you can go ahead.
Okay, good evening, everyone. My name is Ugoze Peter Chukwaloka. I am an affiliate pharmacist from University of Nigeria, Nsukka. So I thank the presenter and I thank the organizers of this platform and of this very important meeting. I so much learned a lot. So my question goes like this: when the presenter was saying something about combining this herbal drugs, it came to my mind that I'm once a culprit of this, because I've used this neem and lemongrass when treating malaria. So I don't know if it's ethically right to combine it like that, because somehow it works for me. When I put a little quantity of alcohol overnight and then take it, it works for me. So I don't know if it's ethically right to practice that way, or to make use of only that name as it is recognized as the best or constituent for treating that anti-malaria. And also, I want to ask, because in some practice, in some villages, like to a layman now, people think that once you take this traditional medicine before taking any orthodox medicine, that like once you're taking it already, it brings out so many other sicknesses in your body. So I want to know if the advice I can give if I find myself in such situations. And some also believe that they can take, after taking orthodox medicine for maybe malaria, they can, after completing the dosage, they can go on with the traditional medicine to at least eradicate it completely. I don't know if it's ethically wise to practice like that. That is my question for clarifications. Thank you.
Okay, thank you very much, Mr. Peter Weze. So my research does not
tomorrow.
I don't think there's anything wrong with taking neem and lemongrass. The what I found out is that neem and somebody is talking. Mr. Ayodele or Stephen. Mr. Stephen. Can the moderator mute them?
Dr. Dimego, you can unmute yourself. It seems network has thrown her out again. I can't seem to see her on the call anymore. Okay, while we wait for her to come back, Pharmacist Zainab, I can see your hand is up again. You can make your inputs. But I would make a request, please, if you can, because a lot of people have made this request for you to be available to us for further learnings. So it would be nice if you can help us probably drop your contact in the chat box so that we can reach out to you, if you wouldn't mind, please.
Thank you for inviting me once again. And I just wanted to do, because I know time is not on our side, but at the same time, there are issues that you can just mention. In addition to what doctor said, I think the pharmacist Ejiro, somebody asked about dose, combination, duration of action, and fast action. Generally, because of the multi-nature and multi-component of herbal medicine, they are known to work slowly but surely. And then for our pharmaceutical drugs, we know we are talking about active principles. You have gotten the active, so it's a striker. It's going to work straight. However, you see in China, when I was told herbal medicine, you can have a component of about 16 different herbs. I asked them, for example, what is this interaction? They have a language, and which you, like I said, when I'm privileged to give a talk, I'll be able to explain it so that we can understand. But I just take, for example, when the guy came, I'm answering 2 questions with that 2 comments. When he asked about lemongrass and neem, you see, in herbal medicine, combination of more herbs tend to reduce toxicity or overexertion of one herb. There is what they call the dominant, the supporters, the assistant in the combination. So when you see experts combine herbs, just like when you are making paracetamol, you take the active ingredient, acetaminophen. You are not only going to give acetaminophen, you have some supporters club, you have binders, you have additives. And those of them, they have a role to play before it goes to the active site, and the acetaminophen, which is the active ingredient, will be released. So also with herbal medicine. So the combination of similar plants with similar characteristics tend to have synergistic effect. Neem tree, when you take overdose, is toxic. Let us all know that. But there is a quantity, like she said. If you take a teaspoonful, our grandparents, at times, if you want to have maximum effect, you take that powdered herb with very, very hot akamu. You remember that? So we didn't know they knew what they are doing. You will come, that means the camu is a catalytic, it is carrier. But you have to understand herbal medicine to be able to understand that. So that is where the issue of combination comes. It's another entirely different topic. And then when you want a striker, you bring two similar herbs. Maybe let me just use 1 second because time is not. My approval of two products which are in capsule form, standardized 500 milligrams of garlic capsule by NAFDAC, which I got approval about 3 months ago. I've started producing, and I'm going to showcase this product in Kano. A combination, you have a combination of about 4 or more herbs combined together. But the dominant one, for example, is garlic. So if somebody who takes garlic in high doses tends to have a burning sensation, that combination of other herbs will tend to neutralize that form of burning combination. So these are things that we can pick up and understand. So I hope I will be able to, when you give me time and the topic, but I want us to really understand what is herbal medicine. We are not getting it as pharmacists. Pharmacognosy is some knowledgeable aspect. But the advantage of a pharmacist is that you can easily understand herbal medicine more than anybody who's, even a doctor cannot understand herbal medicine. Remember, you are apothecarist. You were supposed to prepare medication there and give to the patient. So my observation is that please, some of us should understand it and even start. Those of you that have community practice, you can make a formulation of one herbal product which you can put in your community practice and be telling your patients, the moment your patients believe in you, because at the end we are talking about patient, he will come to you because of that herbal product. You'll be shocked to see the number of patients that are coming to you because they now believe that you are encouraging them and introducing herbal. But if you notice, take a statistic study of people that go to pharmacy shops and people that go to herbal shops. I am so sad. Because for us now, because of no regulation, we have been fighting for regulation so that herbal practitioners can be regulated. We have not gotten that approval. So you cannot tell them to stop giving herbal medicine. What law? You have no law. So, but the indirect law is that if you are qualified, I will go to you rather than the other person. We have them everywhere. Some of them giving wrong prescriptions, and some of them combining the herbal medicine with your orthodox drugs. So these are the challenges we are facing. So the better we learn, the better we stop teaching too much language. And like the engineer, I want to commend her. Do you know that we have over 10,000 species of medicinal plants? I am so sad that all our forests, we have just proposed a bill to prevent these Chinese from going to your villages and going to your farms to buy the whole. Do you know they go to buy the whole tree of for example, shea butter tree? They go to buy the whole zobo that we have. They go to buy the whole kasha tora that we have. So you find that ginger, you cannot buy ginger now. Because you know what? The quality of our ginger in Nigeria is one of the best. So the Chinese will come and they pack your zobo. They pack your ginger. We have white species of zobo. That white species, you can't get it. Why? The Chinese have collected all. But if we more pharmacists go into it, we are going to be fighting for these raw materials that is growing now, and we reduce the exportation, and you find that you are more recognized because a doctor cannot go into producing herbal medicine. Nobody will listen to him, but a pharmacist will be appreciated because that is your knowledge. So I just want to end this by saying this, and when I'm contacted, I'll make available, and I have my books. I have published 9 publications in herbal medicine. I have the first publication, 3 books, was 2001, and by 2020, I reversed those 3 books. So you can try to get in contact. I made it simple so that we can understand it and then we can think about it and we can practicalize it. It's not only reading, but understanding and practicalizing. Thank you for giving me opportunity, moderator.
Okay, thank you very much, Famzina. Please, can you drop your contact for us, please, in the chat box so that we can follow up with you from there? I don't know if you've dropped it already. So, thank you. I can see, okay, if Dr. Ejiro said something else in the chat box. He said, a great point, Dr. Zainab, combination therapy is an established principle. This could be herbal food or orthodox medications. Understanding the outcome is a critical component. So I think that we have come to the end of this presentation. Dr. Joy, I don't think she was able to come back online. She's not, okay, she's back. She's back. I don't know if she can, if she still has anything to say.
Oh no, it has been a very, no, I'm very, has been a very instructive interaction. I'm very happy to have participated. Thank you very much for inviting me.
Okay. Thank you so much for accepting to present to us today. So before we end, I would like to call on the National Chairman of CPAN, Dr. Maureen Wafo, to just give us a few words before we round up.
Good evening, everyone. I'm glad that we're here tonight to listen to this great presentation. I want to start by thanking our dear presenter, Dr. Joy Odumegu. Thank you so much for being here with us. We learned a lot, especially my humble self. Okay. At the time, our dear Professor Bolajoko Aina has been on this call. Prof, we love you. You're always here with us. I cited the Brigadier Stella Ibe too. Thank you for joining us. And some few other stakeholders that have left this call. We thank all of them. Today's topic, I can say, is apt. Just yesterday, I attended drug launch by pharmacist Eken Nailike. Herbal drug launch, 2 drug launch with NAFDAC registration number. He was my classmate. Yesterday was mind-blowing. Juhel Pharmaceutical, the MD was there. Professors from all field of medicine, medical doctors, pharmacists, professors, all of them were there giving testimony what they benefited from these his 2 drugs. It can cure cancer, kidney failure, name them. You see professors giving testimony. Some have gone to overseas for treatment. They couldn't get it, but when they came down here in Enugu and visited this dear colleague, took his herbal drugs and they got the healing. It was mind-blowing. And he has already produced them into capsules registered by NAFDAC. So I want to encourage us pharmacists that it's time for us to really look into this herbal extracts. We are pharmacists. Our core is not just to be giving our patients the orthodox medicine. Let us look into these extracts. They're all at our backyards. We can use them. The most important is for us to get the knowledge. Very important, because our patients are taking them. So we must have to understand them so that we can educate and counsel them accordingly. In my own dear specialty, anticoagulation therapy management, we give our patients warfarin. If you don't educate them concerning food-drug interaction, herbal drug interactions, their warfarin will never work very well. Either they die of stroke or they die of bleeding risk. I had a patient that came for warfarin refill. If look at this man, so thin. I was asking him what should be the problem. Don't you eat again? He said they told him not to be taking anything vegetable that interacts with warfarin. So his wife, after cooking soup, they'll bring out his own white, no vegetable. Then the rest of the family, the wife will now add vegetables for the rest of the family. For over 1 good year. Wow, I screamed. Who taught you that? Can you see? So it's very, very important that we understand this drug-food interaction. Yes, vegetable with very high vitamin K content can affect warfarin, but not that you should not take vegetable. We advocate adequate food, and we advocate the particular food that contains very high vitamin K is what we emphasize on. So we need to really understand all this in very well so that we can as well educate our patients. On this, I want to say thank you, everyone. And our dear pharmacist Zainab, be sure we're going to call on you for more interactive section on this herbal food, drug interaction, and the rest. On this note, I want to inform all of us that we're going to have our program again during PS National Conference. We call it Meet and Greet Program by SIPA on Wednesday, 5th October, during the PS National Conference. So I hope to see all of you there. Please, let's try to attend PS National Conference and make sure you attend SIPA Meet and Greet Program. Also, I want to plead with all of us. Some people are here enjoying CPAN presentations, but they don't update their annual dues. Please try to update your dues. It's not just pay once and become a member, then you stop paying. No, please renew your annual dues and be updated so that we'll continue to move CPAN to a greater height. Thank you so much. We'll see you again, especially in Kano, in more or less than 2 weeks' time. God bless you all.
Thank you. Thank you so much, our national chairman. On this note, we come to the end of this clinical meeting. I would like to call pharmacist Howell Ade. Let me see, what's your full name again? Howell Sadiq Adeshina, if you're still here, to lead us in the closing prayer. Pharmacist Adeshina, are you there? Sadiq Adeshina. Okay, if she's not there, Dr. Suleiman, I don't know if you're still online. Can you lead us in the closing prayer?
Yeah, thank you. We give thanks to God for the opportunity He has given us, having started with His name, and He took us through what we have done. We beseech Him to continue to increase us in knowledge, in piety, and in wisdom. So we hope that when next we meet, we also get a better knowledge from this. So Bismillah Rahman Rahim, Alhamdulillah Rabbil Alamin, Ar-Rahman Rahim, Maliki Yawmiddin. إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. Amen. Good night, everybody.
Amen. Thank you, everyone. Good night. Good night.
Amen.
See you
Thank
next
you.
time.
Thank you.